Carpal tunnel syndrome by me, Deaver. Anatomy. Median nerve. It runs and originates from the ventral roots of C5, 6, and 7, as far and 8, as well as T1. It branches off, as you can see in my picture here, that the branching happens near the wrist area, and then you can see where it runs into the carpal tunnel. Innervations, as far as motor innervations, it highly innervates all of the hand and is responsible for most movement in the hand and finger area. Sensory innervation as well is responsible for much of the sensory innervation in this area as well. Pathology, carpal tunnel syndrome, also called median nerve compression syndrome, is when the median nerve gets trapped underneath the transverse ligament. As you can see, it's a very tight space on my picture, and you can see it where it runs and connects as far as where it connects to the bones. That little space underneath the ligament is where the median nerve does run. As you can see, it's a very, very small compartment. Mechanism of injury. As far as acute mechanisms, there is not really any besides blunt force trauma to where the median nerve runs, as well as fractures of the wrist. Chronically, there's a lot as far as diabetes, obesity, vibrations from using hand tools or power tools, as well as repeated overextension. Mostly happens when playing a piano or typing at a desk. High blood pressure, autoimmune disorders, arthritis, pregnancy, and fluid retention disorders. That mostly happens when someone is pregnant, but can be lifelong in certain cases. Signs and symptoms. Pretty basic in the neurological pathology department as far as signs and symptoms, with burning, tingling, itching, numbness, and weakness, as well as shooting pain. So pretty basic with neurological pathologies there. Predisposing factors, obviously I already said obesity, pianist, office worker, laborer, basketball player because they do a lot of extension, gymnast, same thing in extreme sports. You can imagine how overuse it is from activating a dirt bike. If you ever rode one of those, it's a lot of extension, so can happen in those athletes, but very rare because they are so fit individuals, but still can happen over time, especially if it's in a older population that's riding the bike. Can happen most definitely. Recognition, differential diagnosis. A pretty basic differential diagnosis is arthritis, radiculopathy, median nerve compression at the elbow. I thought that was pretty interesting that it could also happen in the elbow. Obviously it can, but you don't really think about it, that it could originate at the elbow and run all the way down to the hand and cause issues there. So definitely want to spotlight that, work with the neck and work all the way down as we've taught in class. You definitely want to start up top and work down. Some muscle pathology as well here, and as well as other neurological issues with ulnar and cubital tunnel. So definitely want to work up top and work your way down. But it's very indicative, and it's not usually a factor. Differential diagnosis is usually pretty indicative of the condition. As far as special tests go, the technique, we went over this in class, but the technique is the patient places flexed elbows on the table, letting their wrist to fall in maximum flexion, as you can see in the picture. This is the position you want the patient in, and this would happen for 30 to 60 seconds to create or recreate the pain, and it would almost happen automatically as well. Positive indication, and it will increase the symptoms, obviously. 2-point discrimination is the next special test. It's differentiating between what the examiner is touching and what they're touching it with. Pretty much the sharp to smooth, as well as the area they're touching, say the distal finger or the more medial finger, if they can distinguish between the two. That would be the discriminatory part. If you have any further questions, I can send you the link that is listed here, but I give you a brief description. But if you have any questions, I can provide you with the link as well. Management and treatment. Pretty basic management. Rest, ice, heat, NSAIDs, physical therapy to kind of relieve some of that stress. Corticosteroid injections to kind of calm that down, to get some of the inflammation out. But all in all, it's going to end up being a carpal tunnel release surgery, which they go in and cut the transverse ligament to relieve pressure. My grandmother did get this operation procedure, and she had full movement without pain within 1 to 2 days. So outpatient surgery, very quick recovery. You don't need any rehab. Just keep them moving. Should be good between 1 to 2 days. Obviously, NSAIDs, ice within that time for pain management, but very, very, very non-invasive surgery. Furrow and immobilization. I thought it was very neat that there was a brace for this, and it should be worn during sleep to reduce some of that inflammation and pressure and pain during the day, as well as to be able to have the patient sleep at night, because most people sleep with their hands involved in sleep, and that'll increase the pressure in that compartment and make it very uncomfortable. This condition should be referred to a physician because there's not much we can do to relieve that. Like I said, most of it's going to be handled through surgery, but luckily we will not have to deal with most of these because most of the population that gets this is geriatric or is leaning towards geriatric, so it's not really our population, our patient population, unless you're, of course, in a clinical setting, which there's a doctor already there anyway. So, prevention. Avoid overuse, obviously. Practice good techniques as far as working and typing. Avoid that hyperextension. Learn to fall without fooshing to avoid that fracture or blunt force trauma, and maintain a healthy lifestyle to avoid those chronic onset type of things like diabetes, hypothyroidism, stuff like that. Obviously, there's no Mulligan technique because it's not really a mobile ligament there, and it's not really a mobile joint there. So obviously no Mulligan technique, my Peacock, and then references. All right, that's all I have. Thank you everybody for tuning in. I appreciate it, and have a good day.